So now we'll study about the differentiated thyroid cancer, incidence and prognosis. So in United States, the incidence of the thyroid cancer has been tripled in the past 3 decades, mainly due to increased detection of the small papillary thyroid cancer. And in 2010, the incidence appears to be plateauing. And by the year 2030, it is estimated to be second leading cause of cancer in women and ninth leading cause of cancer in man. And several criteria define the prognosis, like risk factor for differentiated, and the most widely used system include the ages, which is age, tumor grade, extent, and the size. And IMAGE is the age, metastatic disease, extrathyroidal extension, and size. And masses is the metastasis, patient's age, completeness of resection, then local invasion and tumor size. Metastasis, age of the patient, completeness of resection, invasion, local invasion, and tumor size. So Mayo Clinic developed this masses criteria in around 1779 patients with papillary thyroid cancer, papillary thyroid carcinoma, PTC, and a low risk is considered when it is less than 6. And so that indicates that 20-year of mortality is around 1%. And this staging system allows clinician to determine the risk of mortality following the initial cancer operation. The ATA clinical practice for DTC also suggests the risk stratification system predominantly designed to predict the disease recurrence, and which guides the post-operative decision making regarding radioactive iodine therapy, TSS suppression, and monitoring. Lymph node status that is not been associated with the cause specific mortality. However, positive lymph node involvement at presentation they increase the risk of locoregional recurrence, and usually favorable prognosis of DTC has been demonstrated by database, in fact showing that other comorbidities are also linked to likely to cause mortality in DTC patients. So the major 35 to 70% patient with follicular thyroid cancer and Hürthle cell cancer present with stage 2 disease, and the presence of predictors of cause specific mortality. Cause specific mortality predictors are age more than 50 years, then marked vascular invasion, and third one is metastatic disease as presentation. If it is metastatic, age more than 50 years, and marked vascular invasion, these are the predictors for cause specific mortality. And MSKCC in 1930 to 1985 they review and showed that age more than 45 years, Hürthle cell subtype, extrathyroidal extension, tumor more than 4 cm, and distant mets. So age, type, then extrathyroidal extension, size more than 4 cm, distant mets, they were associated with the worst prognosis, and 10-year survival was low, intermediate, and high risk group. For low risk it is 98%, for intermediate it is 88%, and for high risk 10-year survival is 76%. And HCC, Hürthle cell carcinoma, is considered more aggressive subtype with high risk of distant mets. Although originally designed for the PTC, AMAGE and AGES scoring system have been used for FTC also, but do not include some prognostic factor like vascular invasion, and which is included in the ATA risk stratification. So genomic characterization of papillary thyroid cancer. Ages we saw, IMAGE, masses. Genomic characterization of papillary thyroid cancer. The molecular driver for papillary thyroid cancer has been largely discovered due to the work of the Cancer Genome Atlas on approximately 500 PTC tumors, and this effort revealed that PTC has a low frequency of somatic alteration relative that occur. So with most frequent alteration being activation, mutation, rearrangement of the MAPK pathway, activating mutation and rearrangement in the MAPK pathway, and this nearly mutually exclusive events occurring in 70% of the PTC, and consist of activating mutation of BRAF, RAS, as well as rearrangement fusion events of the RET and NTRK1. So activating mutation rearrangement of the MAPK pathway, and also activating mutation of the BRAF, RAS, as well as rearrangement fusion events in RAT and TRK1. A single point mutation of BRAF V600E proto-oncogene is recognized as the initiating oncogene trigger in up to 50% of the PTC and may predict poor response in PTC, poor prognosis in PTC with lymph node mets. And other known events include mutation in the TERT, PAX8, PPARG fusion. Although more common FTC mutation in RAS gene family have been found in approximately 10% of the patient, especially with follicular variant of PTC. RAT PTC fusion at present, approximately 40% of the sporadic PTC in adults and approximately 60% children, being most common 80% in PTC caused by external radiation. Rearrangement in NTRK have been found in approximately 5% of the PTC, and TERT promoter mutation have been found to coexist with the BRAF mutation in PTC and are believed to have a synergistic impact on aggressiveness, including tumor recurrence and patient mortality. So genomic characterization of follicular thyroid cancer and Hurther cell cancer. So unlike PTC, FTC is rarely associated with the RAT and BRAF mutation. PAX PPARY gamma 1 gene mutation rearrangements have been identified in a patient and a potential marker of FTC. So for FTC it is PAX8 PPAR gamma 1 in 26 to 56% of the patient. Also been found in the follicular adenoma in 0 to 13% with lag frequency. So RAS mutation are also prevalent in 32 RAS mutation, they are prevalent in 30 to 50% of the FTC, and NRAS being the most common, then HRAS and KRAS. And the detection of the RAS may helpful in detecting patient prognosis since the FTC with RAS, they are associated with more aggressive tumor. FTC with RAS, aggressive behavior and higher potential for mortality. Although PAX8, PPAR gamma 1 and RAS alteration prevalent in the FTC, these are mutually exclusive, and only 3% FTC reported both mutation. And this phenomenon suggests the discrete molecular mechanism responsible for the development of FTC, and similar to PTC, TERT promoter mutation have also been found in approximately 30% of the FTC. And recently comprehensive genomic characterization of 56 primary Hurther cell carcinoma was performed, further enhancing our understanding of this molecular pathogenesis. So pathology of the differentiated thyroid cancer. Grossly, PTC have a variable appearance from subcapsular white scar with a large more than 6 cm that invade nearly structure outside the thyroid gland. And a cystic change like calcification, then even ossification may be identified. And microscopically, PTC presence of papilla, and some variant they have no papillary areas, completely follicular in pattern, identified as a follicular variant of PTC. The major cytological appearance of all the members of this papillary group are characteristic of orphan NEI nuclei. So papillary group having orphan NEI nucleus, that is nuclear groove, and intranuclear pseudo inclusions are there. And in contrast to the overall indolent behavior of the clinical classic PTC, certain variants like tall cell variant, then columnar and diffuse sclerosing, they are also more aggressive. Tall cell, columnar, diffuse sclerosing. Tall cell, columnar, diffuse sclerosing, they are also aggressive. And FTC accounts for approximately 5 to 10% of the thyroid malignancy in non-endocrine goiter area. Most of the follicular pattern of thyroid malignant represents the follicular variant of PTC and share the biological features like natural history prognosis of PTC. Recently encapsulated follicular variant of PTC have been classified as a non-invasive follicular thyroid neoplasm with papillary-like nuclear feature NIFTP, and that was shown to behave like a pre-malignant condition, and the Hurther cell neoplasm is considered a variant of follicular neoplasm although 20 to 33% show evidence of malignancy, 65% have tumor more than 4 cm thought to be malignant.